We're going to be reviewing Chapter 21, Pulmonary Therapeutic Management. To start, let's talk about oxygen therapy. So, the goal of oxygen therapy is to provide sufficient concentration of inspired oxygen to permit full use of the oxygen carrying capacity of the arterial blood. This ensures adequate cellular oxygenation, provided that we have a good cardiac output and our hemoglobin concentrations are adequate for the patient. O2 is a gas that is also considered a medication, and it can be detrimental and beneficial in its effects. Oxygen is usually ordered in liters per minute if it's given via, say, a nasal cannula or a face mask. And then when someone is intubated and on a positive pressure ventilator, it's ordered in a fraction of inspired oxygen, sometimes referred as a percentage. The primary indication for oxygen administration is, as you all know, hypoxemia. And the way that we measure hypoxemia is with the partial pressure of oxygen in the artery that's found on the ABG, and also with our O2 saturation. Oxygen can be administered in a few different ways, but our goal is to maintain a PaO2, or a partial pressure of oxygen, above 60 millimeters of mercury, and then an O2 saturation greater than 90%. If the desired response is met with a particular level of oxygen that we delivered, then we've met our goal, and using the dose-response method, we would maintain at that particular rate of oxygen administration. However, if we evaluate and see that the patient's O2 saturation, say, remained below 90%, then using the dose-response method, we would titrate the oxygen up to obtain an O2 saturation of greater than 90%. And then we can also use the PaO2 to evaluate whether or not we've had an appropriate dose response to the oxygen. There are a few ways to deliver oxygen non-invasively, and those are done with such devices as a non-rebreather. That would be a high-flow method, and then a nasal cannula. Venturi masks are sometimes used when we want to titrate with a mask to a very specific oxygen concentration. And then sometimes reservoirs are added to allow for holding the oxygen in a reservoir that is then inhaled by the patient. So let's do a quick question. Which type of oxygen therapy system is not affected by a patient's breathing pattern? And I'll give you a second to think about this. Okay, so the answer is D, and I'll give you the rationale. Oxygen therapy can be delivered by many different devices. These devices are classified as the three that we identified as low flow, reservoir, or a high flow. A low flow oxygen delivery system provides supplemental oxygen at a rate that's less than 8 liters per minute, or actually 8 liters per minute or less. And the patient's ventilatory pattern affects the fraction of oxygen that is actually inspired by with the low flow system. As the ventilatory pattern changes, differing amounts of room air gas are mixed with the constant flow of oxygen. A reservoir system incorporates some type of device to collect and store oxygen between breaths. When the patient's inspiratory flow or rate exceeds the oxygen flow, then of course they're going to draw in room air. With a high flow system, the oxygen flows out of the device and into the patient's airways in an amount sufficient to meet all inspiratory volume requirements. This type of system is not affected by the patient's ventilatory pattern. So a high-flow system uses either an air entrapment system or a blending system to mix air and oxygen to achieve the desired FiO2. There is no medium flow system. Now, probably the one that you're going to be most familiar with for a high flow system is called a non-rebreather mask. And this is, I think we have an example of this later on. Okay, oxygen, like most drugs, does have adverse effects. And the lungs are designed to handle a concentration of oxygen of 21%. So when oxygen concentrations above 21% are given, oxygen toxicity can develop. And this usually occurs when a patient has been on greater than 50% fraction of inspired oxygen for longer than 24 hours of time. What happens is you have a buildup because of the hyperoxia. You have an overabundance of oxygen-free radicals that damage the alveolar capillary membrane, and that results in the initiation of an acute respiratory distress syndrome, or what's called ARDS. And the free radicals are typically neutralized by enzymes, but the large number produced by the high level of oxygen exhausts the supply of the enzyme to be able to actually do that. So some of the symptoms that you may see with oxygen toxicity: substernal chest pain, dry cough, tracheal irritation, dyspnea, and then pleuritic pain. When normal oxygen concentrations are restored, then symptoms will reverse pretty rapidly unless the patient has been on these for extended periods of time. Okay. In patients with severe chronic obstructive pulmonary disease, COPD, carbon dioxide retention may occur as a result of administration of oxygen in high concentrations. Because of the risk of CO2 accumulation, all patients who are chronically hypercapnic require careful low-flow oxygen administration. Another adverse effect of high concentrations of oxygen is absorption atelectasis. Absorption atelectasis occurs when breathing high concentrations of oxygen washes out the nitrogen that normally fills the alveoli and helps hold them open. And as oxygen replaces the nitrogen, the alveoli start to shrink and collapse. This occurs because oxygen is absorbed into the bloodstream faster than it can be replaced in the alveoli, particularly in areas of the lungs that are minimally ventilated. The key is to ensure oxygen is being administered as ordered and observe for complications. Confirm that oxygen therapy device is properly positioned and replace it after removal. During meals, an oxygen mask should be changed to a nasal cannula if the patient can tolerate it, and then monitor oxygen saturation with the pulse oximeter. Okay, let's do a case study. Mr. Clark presents to the ED in acute respiratory distress. He is a 58-year-old man with COPD, and his vital signs are as follows, and then I'll just let you read that. He can only speak 2 words at a time, is pursed-lip breathing, and exhibits sternal retractions. What information would you like to obtain from Mr. Clark? So, based on what we see here, we can definitely tell that he is exhibiting signs of respiratory failure. He's showing increased work of breathing, his heart rate is elevated, his respiratory rate is elevated, and his O2 saturation is low. And the fact that he can only speak in 2-word sentences tells us that he is extremely short of breath and that he is in respiratory failure. Now, let's take a look at the information you would want to collect here. We'd want to collect when this actually started. We'd also want to take a look at, ask him for a list of current medications that he's on, and then last doses. And then how long has he been in this distress? And then does he have a cough with it? So as we remember, he has COPD. So one of the big concerns here is does he or has he developed pneumonia or some other complication from his COPD? And then of course we'd want to ask him about his smoking history. The key here, though, don't take too long, and you don't want to exhaust him by asking so many questions that you're going to make his respiratory failure worse. So what do we want to do next? So of course, we want to get a blood gas, and we'll want to get a 12 lead EKG, and we'll want to do get an O2 saturation and continue to monitor vital signs. Mr. Clark is fully, based on his blood gas that we see here, we can see that he's in a fully compensated chronic respiratory failure with hypoxemia. The nurse should expect to increase the FiO2 and deliver a treatment of some kind of an aerosol or MDI for a beta-2 agonist and a cholinergic antagonist, something like Duoneb, which would be your ipratropium bromide and albuterol, or the other word for the ipratropium bromide is Atrovent. So that's a common combination of drug that's used for patients who have COPD or say something like asthma, is a Duoneb, which is a combination of Atrovent and albuterol. And you possibly will be administering Mucomyst, type of mucolytic, or guaifenesin, another type of mucolytic, and that will help to mobilize secretions. Now, depending on the appearance of the sputum, you may need to collect, you'll want to collect a sample of sputum, and then depending on the color and the appearance, he may be placed on antibiotics empirically. Mr. Clark has COPD, and he requires a fixed amount of oxygen that can be delivered via face mask. A nasal cannula's delivery is dependent on breathing pattern. Since Mr. Clark is in distress, he's going to be mouth breathing, so a mask in this case would actually be indicated, not a nasal cannula. So a face mask would help to increase his partial pressure of oxygen and also his O2 saturation. And we want to just get his O2 saturation up to 90%, not necessarily 98%. Okay, so moving on, we're going to talk a little bit about artificial airways. There's two common pharyngeal airways, the oropharyngeal airway and the nasopharyngeal airway. These are used in cases where you have obstructions of the upper airway by the tongue. The oropharyngeal airway is really reserved for the patient who is unconscious, and the nasopharyngeal airway can be placed in a conscious patient. You're going to measure so the oropharyngeal airway is measured from the angle of the jaw to the tip of the mouth, to the edge of the mouth. That's where you're going to measure for the size of the oropharyngeal airway. And then for the nasopharyngeal airway, you're going to measure from the nose to the angle of the jaw. Now we move on to endotracheal tubes. So the endotracheal tube is used most commonly, and it's the most common artificial airway for short-term airway management. And indications for endotracheal intubation basically include when someone cannot maintain their own airway, to protect against aspiration, application of positive pressure ventilation, facilitation of pulmonary hygiene, and then sometimes it might be used to administer high oxygen concentrations. An endotracheal tube may be placed through the orotracheal route or the nasotracheal route. I would say in general, it's fairly rare to see nasotracheal intubations. A time where it might be indicated is, say, with someone who has some kind of a facial trauma that would necessitate the need to intubate via the nasotracheal route. ET tubes are available in different sizes, which are based on the inner diameters of the tubes, and they have a radiopaque marker so that when it's placed, a chest x-ray can be taken to ensure proper placement depth. And the balloon is typically inflated to 15 to 25 millimeters of mercury. And there's a small pilot balloon. Let me activate my little laser pointer. So you can see here there's a little pilot balloon, and this is where this balloon here is inflated from. And I'll show you a little more details here in a minute. Now the process for intubation is called rapid sequence intubation, and it's a 7-step process that is often used to intubate critically ill patients. And it is considered safer for the patient because it decreases the risk of aspiration. It's a rapid series of events that we perform. So here are the first 5 steps. You got to prepare all your equipment, which would include suction equipment, a bag valve mask, your laryngoscope, and then all the equipment associated with actually performing the intubation. The next step is the pre-oxygenation phase. This is where we administer 100% oxygen for 3 to 5 minutes via a tight face mask to eliminate all the nitrogen from the lungs and create a reservoir of oxygen. So we wash out all the nitrogen, and a patient's lungs will hold about 6 to 8 liters. And so when we wash out all the nitrogen, we've replaced it with oxygen, and the patient can actually be paralyzed up to 3 to up to 10 minutes, and the O2 saturation will be maintained above 90% because of that washout of nitrogen and the replacement with oxygen. Step 3 is pre-treatment. Step 4 is paralysis with induction. And then step 5 is protection and positioning. So in the pre-treatment phase, this is when we're going to be administering drugs, a couple of different drugs potentially that will help to blunt the physiologic response. You may see lidocaine, fentanyl, atropine be given in these cases. And then in step 4, this is the paralysis with induction phase. And the typical drugs that are given are either succinylcholine or rocuronium. Succinylcholine is a fasciculating agent. So what that means is it's a paralytic agent that actually causes fasciculations prior to the patient becoming paralyzed. And the normal dose is 1 milligram per kilogram. So if you know the patient's weight, then you have the dose based on the weight. So if they weigh 80 kilos, then they're going to get 80 milligrams for the dose. And in general, succinylcholine is the most common drug that is used for paralyzing the patient. Step 5, protection and positioning. A pillow should be placed under the head to put the patient in the sniffing position. The larger the patient, for instance, an obese patient, would require more padding underneath the head to get a better visualization of the cords for the person that's intubating. All right, and we have step 6 is actual placement of the ET tube, and you can see that as the laryngoscope is placed with the laryngoscope is held with the left hand, the ET tube is placed, and the trachea is the anterior tube in the patient's throat there that you can see based on the picture. And so let's fire up our laser pointer real quick. So the trachea is the anterior tube, and then the esophagus is the posterior tube. And the nurse obviously won't be the one performing this, but I think it's a good idea to understand the the positioning, the way the airway is structured. And then up here, right up here, you can see the ET tube, the end of the ET tube. This is where the end-tidal CO2 monitor or calometric capnographer will be placed to detect whether or not it's actually in the airway. Okay, once the tube is placed, then you're going to do your post-intubation management. This is securing the endotracheal tube. This, as you can see in the picture, we have a securing device. It's a commercial securing device. It wraps around the back of the neck, and then it holds the ET tube very tightly. And the place where we measure the endotracheal tube depth is right there at the teeth. And the endotracheal tube should be sitting just right about there. If we could, see through the patient, you would see that the endotracheal tube is placed about right there. And the way that we assess it is we look at the end-tidal CO2 and we look for the square wave, and the reading should be between 35 and 40. And then if we're using a colorimetric capnographer, it will turn from purple to gold. And that's how we know that we are in the proper hole, or we're in the trachea, not the esophagus. And then also we will want to listen to breath sounds bilaterally and ensure that we have good chest rise and fall. And finally, we'll get a chest x-ray to validate placement. There are some complications that can occur due to intubation, and those would include things like nasal or oral trauma. Also, you may get vomiting and aspiration. And worst of all, if the patient becomes hypoxic for a period of time, they may actually suffer cardiac arrest. There are other complications that you can read about in your book, and I'd advise that you do that. Hypoxemia and hypercapnia can also occur, and then you can develop bradycardias, tachycardias, and then other dysrhythmias, and then as well hypertension and hypotension. One of the things that we monitor for post-intubation is ET tube placement, so we're going to be evaluating at regular intervals the breath sounds to ensure that the tube remains placed correctly. Okay. So next we're going to move to tracheostomy tubes and look at the indications, the actual procedure, and then the complications. So a tracheostomy tube is actually the preferred method for airway maintenance if the patient is going to be intubated for longer than 7 to 10 days. Often we don't know initially whether they're going to be intubated for periods longer than that, so you usually don't see this performed right immediately in say an emergent situation. Now, if an airway is not able to be established, then we would perform a different type of a procedure called a cricothyroidotomy, a little bit different than a tracheostomy, and this is performed usually by, well, definitely by someone who's experienced, but usually it's going to be either surgery or anesthesia that would perform the tracheostomy, or excuse me, that would perform the cricothyroidotomy. And this is basically a damage control type of a procedure. Okay. Now, the tracheostomy can be placed via a couple of methods. One would be actually an open procedure, and then the second would be the percutaneous procedure. This is actually the preferred and most used in today's ICUs, would be the percutaneous procedure, which can be done at the bedside. And of course, just like any other procedure, there can be some complications that we need to consider, and they are usually self-apparent. One would be misplacement of the tracheal tube itself, hemorrhage, laryngeal nerve damage, and then pneumothorax, pneumomediastinum, and then ultimately cardiac arrest. And the same ones that apply for endotracheal tubes, such as the dysrhythmias that you may see, like if you have a hypoxic period, then you may develop the patient may develop bradycardias, tachycardias, and so forth. Okay.
Let's go to sleep. Sorry. She's tired and I don't have a place to sit.
Okay. Next up, we have, so here's a couple of pictures. So on the right side, we have a type of tracheostomy called a fenestrated tracheostomy. And then on the left side, we have your standard regular tracheostomy. The one on the right allows the patient to be able to speak. And you can see they're very similar to endotracheal tubes, except they have a thing called an inner cannula, and they're actually much shorter. They completely bypass the upper airways, and this is something that we need to take into consideration as we place the patient on this. And as well, the endotracheal tube bypasses the upper airways. One of the main things that the upper airways do is humidify the incoming air, and so with both endotracheal tubes and with tracheostomies, humidification plays a part in nursing management. And The machines that we place patients on will provide warm, humidified air through the tubing. Cuff maintenance is important, and I'm going to fire up the laser pointer, and you can see this is a cuff pressure monitor, and the green zone is where we would want the cuff pressure to be maintained. This is checked typically a couple of times per shift. Usually respiratory therapy will check it, but the little cuff monitor is usually left at the bedside, and if you have concerns or if you hear a cuff leak, then you can check the pressure and increase it to the appropriate pressure. The pressure should be around 20, and you can see there's a green range there between 15 and 25. The pilot balloon is connected to this little port, and then you can get the measurement, and then you can squeeze the little rubber air import right here. If the balloon is pumped up too heavily, then you can actually release some of the air from this red button. Okay, and we pretty much discussed that. So, with artificial airways, one of the new features that we have is actually this thing called subglottic suction. And both for tracheostomies and for endotracheal tubes, you can see this extra port here. This extra port connects to suction, and we can apply a low pressure suction, and there's a little hole right here above the balloon, and that allows for, if secretions pool around the upper part of the balloon, then those can be suctioned out and then removed. Research has shown that by applying subglottic suction at, say, either at a continuous or intermittent level, that we can reduce the likelihood of ventilator-associated pneumonia by about 50%. Nurses are responsible for suctioning, and this is a sterile procedure. Nowadays, we use a closed suction system that allows for continuous sterility of the suctioning unit. And you can see here that there's an irrigation port. We usually do not use the irrigation port. This is research has shown that putting saline down the endotracheal tube really does not help facilitate suctioning. However, sometimes there is a need to use a lavage in the case of when they're doing a bronchoscopy down the endotracheal tube. That's where they can target the saline and remove any secretions that they can see. Complications from suction include hypoxia. That's probably the biggest one you have to concern yourself with, and that we always pre-oxygenate. Some other things that we need to consider are atelectasis, bronchospasms, dysrhythmias, and then increased intracranial pressure. If we have someone with head trauma, we want to try to limit the amount of suctioning we do to prevent increased intracranial pressure. And then, of course, when you're placing a large tube down into the trachea, this tube right here, this tube can actually damage the trachea. So it's important when you're passing it down into the patient, you don't apply suction while you're going down, and then as you remove it in a nice smooth pace, and just be careful with this procedure. And of course, before you suction, you always want to hyperoxygenate the patient for about a minute or so to ensure that you wash out some nitrogen and replace it in the lungs with oxygen so that you can ensure to maintain a good O2 saturation. Okay. A number of interventions can facilitate communication in a patient, and one of them is this. In the picture, you can see that there is a device on the tracheostomy called a passe-mur valve. This actually allows for the patient to inhale air, and then it acts as kind of a fake vocal cords and allows for communication. There are other devices out there that will facilitate the ability of the patient to verbalize. And I think it's also important to facilitate communication by allowing the patient to wear their eyeglasses or putting hearing aids in. Methods to facilitate communication in elderly population, this is very important. So, and nonverbal language can be very challenging for anyone who's intubated. Okay. Another intervention that is very important is oral hygiene. Patients with artificial airways are extremely susceptible to ventilator-associated pneumonia, or VAP, because of microaspiration of subglottic secretions. The subglottic suction is another thing that will help to prevent that. These secretions are full of microorganisms from the patient's mouth. Because of the cuff or the artificial airway, if it isn't tight, doesn't create a tight seal, then the fluids can leak down into the lungs, and then ventilator-associated pneumonia can set in. As well, proper oral hygiene is very important, and we've discovered through research that simply by using a rinse and a swab of the patient's mouth with 15 cc's of 0.12% chlorhexidine every 12 hours, we can actually significantly reduce the likelihood of ventilator-associated pneumonia. Now, after the airway is no longer needed, it should be removed. Extubation is the process of removing the endotracheal tube, and basically decannulation is the process of removing a tracheostomy, and extubation is the process of removing an endotracheal tube. They are both simple procedures. They can be performed at the bedside, but it's just important to ensure that you have the proper equipment there, that you are ready in case the patient does not have a successful extubation, that you're able to re-intubate the patient. Something to consider. Okay, so moving into the types of invasive mechanical ventilations, there's really two primary types: positive pressure ventilators and negative pressure ventilators. Nowadays, we really only use positive pressure ventilation, and as you all know, mechanical ventilation is the process of using a ventilator or an apparatus to facilitate the transport of oxygen and CO2 between the atmosphere and then the alveoli. That's really what you're doing when you're providing mechanical ventilation. And the physiologic objectives of this is to support cardiopulmonary gas exchange and reduce the work of breathing. And the objectives is to reverse hypoxemia, sometimes you may see acute respiratory acidosis, and those are the things that we're trying to reverse. And then we do want to relieve respiratory distress and prevent atelectasis and respiratory failure and fatigue. Now, sometimes we may need to sedate the patient and provide neuromuscular blockade, and we just have to be aware that when we mechanically ventilate someone, sometimes it's not tolerated very well by the patient, so sedation is often needed. Okay. Now, the mechanical ventilation really is done in 4 phases. The ventilator must complete the 4 phases of ventilation to properly ventilate. The first phase is a change from exhalation to inspiration. The second phase is inspiration. The third phase is the change from inspiration to exhalation. And then finally, the 4th phase is exhalation. The ventilator uses 4 different variables to begin, sustain, and terminate each of these phases. These variables are described in terms of volume, pressure, flow, and time. And I want to say that again because I think it's good to just be able to kind of get this committed to memory. So these variables, the way the ventilator turns on and off the ventilation cycle, is by volume, pressure, flow, and time. Each one of those 4 variables are important, and we're going to talk about that a little bit. So, the phase variable that initiates the change from exhalation to inspiration is called the trigger. So, basically what that means, to put that in more of a layman's terms, is the patient, if the patient initiates a breath, that could be a trigger. And that trigger might be a pressure that's generated by the patient's beginning to take the breath in, or a particular flow that's generated. So the trigger can be a flow or a pressure, and that's what's or a volume, and that's how how the ventilator is going to be triggered. Now, breaths may be pressure triggered or flow triggered depending on the sensitivity setting of the ventilator and the patient's inspiratory effort, or they may be time triggered depending on the rate setting of the ventilator. The variable that maintains inspiration is called the limit or target. So let me repeat that. The variable that maintains inspiration is the limit or target. So inspiration can be pressure limited, flow limited, or volume limited. So let's rephrase that in layman's terms. So if a patient is on a pressure limited setting, then when the breath goes in, once a certain pressure is reached, then the breath will cycle off. And then if flow is is the limiting factor or the target, then once a certain flow is reached, then it will cycle off once that certain target flow is reached. And then finally, if that certain volume, say they have a volume limit set at 600, once that volume target is reached, then it will cycle off and then go into expiration. The variable that ends inspiration is called the cycle. The classification of positive pressure ventilators is based on this variable. So here are a few examples: volume cycled, pressure cycled, flow cycled, and time cycled ventilators. The variable that is controlled during exhalation is called the baseline. Okay. The term ventilator mode refers to how the machine ventilates the patient. Selection of a particular mode of ventilation determines how much the patient will participate in his or her own ventilatory pattern. The choice depends on the patient's situation and the goals of the treatment. The mode is determined by the combination of phase variables selected. Now, settings on the ventilator allow the ventilator parameters to be individualized to the patient and also allow selection of the desired ventilation mode. Each ventilator has a patient monitoring system that's built in that allows all aspects of the patient's ventilatory pattern to be assessed, monitored, and displayed. Now let's talk about some complications related to ventilator, such as ventilator-induced lung injury and then cardiovascular compromise. Mechanical ventilation is often life-saving, but like other interventions, it does have its own complications. Some complications are preventable, whereas others can be minimized but not eradicated. Mechanical ventilation can cause two different types of injury to the lungs. One is air leaks and biotrauma. Air leaks are the result of excessive pressure in the alveoli, sometimes referred to as barotrauma. Excessive volume in the alveoli is called volutrauma, or shearing due to repeated opening and closing of the alveoli. This is actually called atelectrauma, and that's because of the shearing forces of positive pressure ventilation. Barotrauma, volutrauma, and atelectrauma can all cause the release of cellular mediators and initiation of the inflammatory immune response. This type of ventilator-induced injury is called biotrauma, and that's spelled B-I-O-T-R-A-U-M-A, biotrauma. Positive pressure ventilation increases intrathoracic pressure, which decreases venous return to the right side of the heart. So this is an important thing to understand, because if a patient has impaired venous return, that's going to decrease preload, and then ultimately that's going to impair cardiac output. As a secondary consequence, hepatic and renal dysfunction can occur. Positive pressure ventilation also impairs cerebral venous return. In patients with impaired autoregulation, positive pressure ventilation can result in increased intracranial pressure, so something to be considered. So let's take a quiz. What is trauma caused by excessive pressure in the alveoli during mechanical ventilation called? So I'll give you a second. So what we're talking about here is excessive pressure in the alveoli. And if you said answer B, that's correct. So mechanical ventilation can cause two different types of injury to the lungs: air leaks and biotrauma. Air leaks are the result of excessive pressure in the alveoli and excessive volume in the alveoli, or shearing due to repeated opening and closing of alveoli. Barotrauma, volutrauma, and atellect trauma can also cause the release of those mediators we talked about. Now, this type of ventilator-induced injury is known as biotrauma. So, invasive mechanical ventilation can cause gastrointestinal disturbances and also patient-ventilator dyssynchrony. So, gastrointestinal disturbances can occur as a result of positive pressure ventilation, and gastric distension occurs when air leaks around the endotracheal tube or tracheostomy and overcomes the resistance of the lower esophageal sphincter. Vomiting can occur as a result of this, and hypomotility and constipation may also occur as a result of the immobility of the patient, since they are often on paralytics and sedatives and analgesics. Because the ventilatory pattern is normally initiated by the establishment of negative pressure within the chest, the application of positive pressure can actually lead to patient difficulties in breathing while on the ventilator. I've not been intubated, but I've talked to patients who have, and they say it's very difficult to get into sync with the ventilator. So to achieve optimal ventilatory assistance, the patient should breathe in synchrony with the machine. And one of the things that actually does help with this is sedating the patient mildly. And sometimes if ventilator dyssynchrony is very bad, then it may be required, the patient may be required to have paralysis. Now, ventilator-associated pneumonia. Ventilator-associated pneumonia is actually one of the complications to being intubated. However, we found that we can greatly reduce the risk of ventilator-associated pneumonia by performing seven or eight different tasks. Number one, keeping the head of bed up greater than 30 degrees is paramount, and it greatly reduces the risk of ventilator-associated pneumonia. Number two, providing daily sedation vacations. Number three, providing prophylaxis for peptic ulcers. Number four, providing prophylaxis for deep vein thrombosis. These patients are often sedated and immobilized for long periods of time, so that puts them at risk for deep vein thrombosis, which will set them up for pulmonary embolism and also for ventilator-associated pneumonia. Daily oral care with chlorhexidine, and as we talked about before, this should be performed every 12 hours with 0.15% chlorhexidine. And subglottic suction is another thing that we talked about that will help to reduce ventilator-associated pneumonia. So there's a couple of other things that we've talked about. So that's semi-recumbency, sedation vacation, and then the subglottic suction are the three big things that we can really focus in on to help prevent VAP. So let's jump back on our case study, or a different case study. Mr. Clark was admitted to the ICU with a diagnosis of community-acquired pneumonia. He became increasingly short of breath, lethargic, and required intubation with mechanical ventilation. He was tolerating ventilation until he suddenly became agitated and began fighting the ventilator. What are the potential causes of this agitation? Okay, so we'll give you a second to think about the potential causes of his agitation. So, Mr. Clark may require sedation since he is uncomfortable on the ventilator. Other causes should also be explored because there are causes that can be life-threatening that we need to make sure that he doesn't have. A few would be something like pneumothorax, mucus plug, myocardial infarction, pulmonary embolism, increased hypoxemia from an unrecognized ventilator disconnect, or the patient might have delirium. He should have a focused assessment including vital signs and lung auscultation. He could be taken off and bagged while on the ventilator while the ventilator circuit is checked and assessed for suctioning and for pain. If no immediate cause is noted, then he may require a test to determine if there's a problem. Some of the tests that you may be asked to order or that you may be asked to perform or help participate in is lab work, chest x-ray, ABGs, or even a CT scan. So this is just a picture that demonstrates the pathogenesis of ventilator-associated pneumonia. And let me just pull up my laser pointer. You can see we start off with the intubation procedure. Here's the epiglottis. The endotracheal tube is inserted, the balloon is inflated, and we can see that over time a biofilm can grow over the surface of the endotracheal tube. Secretions can build up at just above the balloon at the subglottic point, and then the contaminated secretions can leak down into the lungs and then contaminate the sterile bronchioles. So we can go back to our VAT bundle, those 7 treatments that to help prevent this. Now on to weaning. Weaning is the gradual withdrawal of the mechanical ventilator and the reestablishment of spontaneous breathing. Weaning should begin only after the original process for which the ventilator support was required has been corrected and the patient's stability has been achieved. Major factors that affect the patient's ability to wean include the ability of the lungs to participate in ventilation and respirations, and also cardiovascular performance and psychological readiness. This discussion just simply focuses on weaning of the patient from short-term or what would be called less than 3 days mechanical ventilation. So less than 3 days of mechanical ventilation the patient will not have become dependent upon the ventilator. They should be able to be weaned if their underlying disease process has been managed correctly. So management of weaning in the patient on a long-term mechanical ventilation is discussed in Chapter 20. Patients should be screened every single day for their readiness to be weaned. The screening should include an evaluation of the patient's level of consciousness, their physiologic and hemodynamic stability, their adequacy of oxygenation and ventilation, their spontaneous breathing capability, and then finally their respiratory rate and breathing pattern. One of the tools that is used for determining the readiness for extubation, or weaning I should say, is the Rapid Shallow Breathing Index. This Rapid Shallow Breathing Index is very good at predicting weaning success. After the patient's readiness to be weaned has been established, the patient can be prepared for the weaning trial. The patient is positioned upright to facilitate breathing and suctioning if needed. The process is explained to the patient, and the patient is offered reassurance and diversional activities. The patient is assessed immediately before the start of the trial and then frequently during the weaning period for signs of intolerance. The three main methods for weaning are: number 1, T-tube trial; number 2, synchronized intermittent mandatory ventilation; and then 3, pressure support ventilation. Now, regardless of the method that you select, the evidence shows that using a standardized approach is really what makes the weaning successful. T-piece weaning trials consist of alternating periods of ventilatory support with just the patient breathing on their own with a T-piece and oxygen being delivered. In between, the patient should be placed on some type of ventilation that will fully support them and provide rest, with a goal to progressively increase the duration of time spent off the ventilator. Now, with SIMV, the goal is to gradually transition from ventilatory support to spontaneous breathing. It is initiated by placing the ventilator on SIMV mode and then slowly decreasing the rate, usually 1 to 3 breaths at a time until the rate is 0. And after this is reached, an arterial blood gas sample should be drawn 30 minutes after the trial to see how the patient tolerated it. Now, pressure support ventilation weaning consists of placing the patient on the pressure support mode and then setting the pressure support at a level that facilitates the patient achieving a spontaneous tidal volume of somewhere between 10 to 12 milliliters per kilogram. So if the patient weighs 80 kilograms, then we would anticipate that they would have a tidal volume of about 800 mils. Okay. Now, pressure support augments the patient's spontaneous breathing with a positive pressure boost during inspiration. During the weaning process, the level of pressure support is gradually decreased in increments of 3 to 6 centimeters of water. Okay. So, while the tidal volume is maintained, we're hoping basically as we decrease the pressure that the patient will continue to maintain a tidal volume of somewhere between 10 and 15 cc's per kilogram. And finally, our bottom threshold for the pressure that we're going to reach is 5 centimeters of water. This 5 centimeters of water is simply going to be enough to overcome the resistance of the endotracheal tube. And if the patient can tolerate 5 centimeters of water of pressure, and then they will most likely be able to be extubated successfully. So now we're going to talk about the nursing management of a patient on an invasive mechanical ventilator. So management includes a total, in total, we're going to do patient assessment with a particular emphasis on the pulmonary system. We're going to be assessing the placement of the endotracheal tube or the tracheostomy. We're going to be observing for subcutaneous emphysema and any dyssynchrony with the ventilator. We'll also be doing a bedside evaluation of vital capacity, minute ventilation, ABG values, and other pulmonary function tests that may be warranted or ordered according to the patient's condition. Patients that require mechanical ventilation may present with a variety of disturbing symptoms. These symptoms are often managed with sedation and analgesia. These medications also can contribute to prolonged mechanical ventilation and actually delirium. Non-pharmacologic interventions should be attempted. Some of those non-pharmacologic interventions include promoting sleep, reducing anxiety, music therapy, guided imagery, nursing presence, animal-assisted therapy. Those are some of the primary non-pharmacologic interventions that you may see used and that you may use yourself. Another bundle that has recently been proposed is the Awakening Breathing Coordination Delirium Monitoring and Early Mobility Bundle. This is called the ABCDE bundle. We discussed this back in our first lecture If you can remember back to week 1, we talked about the ABCDE bundle. This bundle focuses on enhancing communication between the team members in the critical care unit, standardizing patient care processes, and decreasing the incidence of delirium. Assessment of the ventilator also includes a review of all the ventilator settings and alarms. A clear understanding of the alarms and their related problems is important. The peak inspiratory pressure, the exhaled tidal volume, and ABGs are also monitored. Several measures are required to maintain a trouble-free ventilator. These include maintaining a functional manual bag valve mask that is connected to oxygen at the bedside, and then also ensuring that the ventilator tubing is free of water. The ventilator tubing should also be positioned to avoid kinking, and then maintaining patency of the ventilator tubing is absolutely essential. Now, changing the ventilator tubing is really according to hospital policy, and the monitoring of the temperature of the inspired air is also performed by the respiratory therapist. Now, if the ventilator malfunctions, the most important measure that you can take is actually removing the patient from the ventilator and then providing manually bag valve masked ventilations. I can't stress enough that you don't want to rely on the ventilator in the event that the patient seems to be experiencing some kind of complication with their respiratory system. So that's where you want to remove them from the ventilator and bag valve mask. So let's do another case study. After 3 days of antibiotic therapy, Mr. Clark's chest x-ray and sputum are now clear. His white blood count is normal and he is breathing comfortably. What assessment findings would let the nurse know Mr. Clark is able to be weaned or liberated from the ventilator? So I'll just give you a second to think about that. What assessment findings would let the nurse know that Mr. Clark is able to be weaned or liberated from the ventilator? Take some notes. So, Mr. Clark is showing signs that his pneumonia is resolving, so the condition that caused him to require mechanical ventilation has improved. Assessment of vital signs, oxygen saturation, his nutrition status, a lack of vasopressors, and then his stable breathing patterns are things that you're going to want to assess. Now, other criteria would include the ability to maintain adequate oxygenation with minimal ventilatory support. So this would really mean a fraction of inspired oxygen on the ventilator of less than 50%, a PEEP of less than 8, and then a PaO2 that is well above 60 millimeters of mercury. Daily weaning assessments also include a rapid shallow breathing index, which should be less than 105, and then this person will always have a spontaneous breathing trial prior to participating in a weaning trial. Okay. Now we're going to discuss non-invasive ventilation. Non-invasive ventilation is an alternative method of ventilation that uses a mask instead of an endotracheal tube to deliver therapy. The advantages of this type of ventilation include it decreases the frequency of hospital-acquired pneumonia. It also is more comfortable for patients, and then it is non-invasive in nature, which allows for easy application and removal. It is indicated in type 1 and type 2 acute respiratory failure, also in cardiogenic pulmonary edema, and other situations which intubation is not an option. Non-invasive ventilation can be applied with a total face mask or a nasal face mask, and sometimes these are referred to as BiPAP. You may have heard that. This type of ventilation uses a combination of positive pressure ventilation and positive end expiratory pressure, and this basically is how the ventilator supports ventilation. And it's really the So let me rephrase that. This type of ventilation uses a combination of This type of ventilation uses a combination of pressure support ventilation and positive end expiratory pressure supplied by a ventilator, or inspiratory and expiratory positive airway pressure. These devices do have built-in humidification along with supplemental oxygen, and so they will help support any hypoxemia that the patient may have, and it will provide humidification for the loosening of secretions. Nursing management of the patient receiving non-invasive ventilation can be reviewed in box 21-9. Routine assessment of these patients includes monitoring for patient-related and ventilator-related complications. Respiratory rate, accessory muscle use, and oxygen status are continually assessed to ensure that the patient is tolerating this method of ventilation. Now, continuous pulse oximetry should also be used. The key to ensuring adequate ventilatory support is a properly fitted mask. With non-invasive ventilation, let me restate this, with non-invasive ventilation, a properly fitting mask is one of the most important features. The patient is first positioned with their head up at a 45-degree angle to minimize the risk of aspiration, and then this also helps to facilitate breathing. And then the mask is applied, and then you monitor the patient. Complications include insufflation of the stomach and gastric distension, and these patients need to be monitored for that. Often patients are very anxious and have high levels of dyspnea before the initiation of the non-invasive ventilation. Afterwards, adequate ventilation has been established, then their anxiety and dyspnea are usually sufficiently relieved. So let's move on to positioning therapy. We've reviewed prone positioning in another lecture, but just wanted to put it out there that the whole point in positioning therapy is really to improve the ventilation perfusion matching. And when we perform continuous lateral rotation therapy, that is what we're targeting, is the improvement in perfusion to the less damaged areas of the lungs, and then improving the ventilation perfusion match. Prone positioning can be used to facilitate the mobilization of secretions and provide relief. However, it can be contraindicated in patients with hemodynamic instability and increased intracranial pressure and other injuries such as spinal cord injuries and abdominal surgery. And frankly, positioning a patient prone can present many challenges, which sets the patient up for complications of getting accidental tube removals and different things like that. So something to consider. Okay. So some of the pharmacological agents that are used for patients who are intubated are bronchodilators and bronchodilator adjuncts, as well neuromuscular blocking agents. When we give neuromuscular blocking agents, we will also be performing peripheral nerve stimulation tests to ensure that the patient is properly paralyzed. So, to review, oxygen is a medication, and the primary indication for its use is hypoxemia. Oxygen can be delivered by various methods, and we talked about the low flow system, the reservoir system, and the high flow systems. And then there are complications of oxygen therapy, and we need to be considering those things. And so we're talking about oxygen toxicity, CO2 retention, and absorption atelectasis. The placement of artificial airways are used to maintain airway patency and to keep the tongue from obstructing the upper airway. ET tubes are used to maintain airway patency and to protect the airway against aspiration, and to facilitate access to invasive positive pressure ventilation, and also to aid in secretion removal. Complications of ET tubes, although they are rare, they can happen, and the more common would be the tube obstruction, tube displacement, and sinusitis is actually not that uncommon. And then some other more rare complications would be nasal injury, tracheoesophageal fistula, mucosal lesions, laryngeal or tracheal stenosis, and cricoid abscess. Tracheostomy tubes provide the best method for long-term airway maintenance, and if you anticipate the patient will be intubated longer than 7 to 10 days, they should have a tracheostomy placed. Complications of tracheostomy are very similar to the complications to endotracheal tubes, so I will not go through that in depth. And cuff pressure for both ET tubes and for tracheostomy should be maintained between 20 and 25 millimeters of mercury of pressure, and that's performed by the pilot. Humidification is required for ET tubes and tracheostomy tubes because we bypass the normal airway's ability to be humidified. All right, a few more complications. I'll let you review these. We know now that oral care is important, and that chlorhexidine gluconate is the best thing to use, along with performing that cleaning of the mouth every 12 hours. And we should remove the ET tube as soon as possible, depending on the patient's condition. So, indications for invasive mechanical ventilation include cardiopulmonary gas exchange, increased lung volume, and reducing work of breathing. And then complications include lung injury, cardiovascular compromise, gastrointestinal disturbances, patient ventilator dysynchrony, and ventilator-associated pneumonia. Strategies to help prevent VAP include sedation vacations, peptic ulcer prophylaxis, deep vein thrombosis prevention, prophylaxis, oral care, subglottic suction, and then weaning is a gradual process of removal from the mechanical ventilator, and we need to make sure that the patient can withstand a spontaneous breathing trial prior to initiating weaning. All right, now positioning therapy. We've gone through that. I'll let you just take a look at these slides and read them. So remember, with positioning, it's all about improving the ventilation to perfusion matching, and this is often most safely achieved by simple lateral rotation therapy. Most of the beds that we use nowadays in the ICUs have the capability to laterally rotate. We covered pharmacologic agents. I did not mention steroids, but steroids are often used in conjunction with beta-2 agonists to enhance their anti-inflammatory effects. Sedation and paralysis. Sedation is almost always needed for adequate maintenance of mechanical ventilation, and every now and again you may need to neuromuscularly paralyze the patient to get them to be able to be synchronous with the ventilator appropriately. And then we definitely want to avoid prolonged neuromuscular blockade, because it's been shown that patients who are on prolonged neuromuscular blockade may have complications and problems weaning off the ventilator.